So we have Greg Woods here today. He is from the Iowa Department of Human Health and Services, and he is going to be doing a program that he's going to tell you a lot about. And here's Greg.
Well, thank you very much for coming out here, everybody. This is awesome to see, and I am thrilled to be able to present the program today. As a little background on myself, I am the program coordinator for the Alzheimer's disease and related dementias program at Iowa HHS. Now, if you're not familiar with Iowa HHS, we used to be the Iowa Department of Public Health. Still do the same things, we're just going by a slightly different name now. And if you haven't heard of our program, don't blame you, we haven't been around that long. We've only existed for about 5 years now, and I joined at the program's inception. So I've been here for the whole duration of it, and we'll talk a little bit about what the program does later on in the program. If you want to go before that, I was a one-person office for 5 years over in Fort Dodge for the Alzheimer's Association. So I was a one-person office, and I traveled all around north central Iowa doing everything from care consultations, support groups, workshops, whatever was needed. And during that time, and continuing into this time, as I go to different towns, it's given me an appreciation for the utility of a library. And that's why I think this is the perfect place to talk about this subject. Libraries are often trusted sources of information. People go to them to try to figure out something, whether it's information or next steps or resources, whatever it might be. So we'll talk a little bit about that and more later on. If you want to go even farther back for me, I'm originally from Newton, so lifelong Iowan, went to school down at Drake in Des Moines, got my degree in neuroscience, headed off to the University of Iowa, did a little bit of med school, but finished up in public health, and I've loved it ever since. So I'll try to weave through several different elements of that in the program today. We exist because of a bit of nationwide bipartisan legislation called the Bold Infrastructure Act. And you don't need to go into great detail about that, but the whole point of that is the Healthy Brain Initiative at the CDC is giving states money to build up dementia infrastructure, connect the dots, make sure that people can get the resources that they need. And we'll discuss that toward the end, how that fits into what we do. But if you get nothing else from this program today, absolutely nothing else, please be willing to talk about this after you leave. Go tell one person, hey, I went to this program. Hopefully you learned something. Hopefully you think it's an okay program. But when you talk about it, the point of that is to drive down the stigma that surrounds this disease. And if you've done anything in dementia in the past, you know there is absolutely a stigma surrounding this disease. It's not something that people really like to talk about. They don't like to think about it unless they absolutely have to. So if we can go out and talk about this program, that helps to pierce that veil a little bit. It helps to drive down the stigma and normalize the conversation. If we don't do that, all the resources that we offer and the things that we do are not going to be heard. So hopefully you'll do that. I'm not going to assume, but hopefully you'll feel that way. In terms of specifics, I always like to start off with, what is dementia? What is Alzheimer's? Are they the same? Are they different? How are they related? What is our understanding of this disease? Both where did it come from, where is it now, and hopefully where is it going in terms of research? How do we get it? What can affect risk for getting this disease? Are there things that can tip the scales one way or the other to either increase our risk or hopefully decrease our risk? Why do we talk about this? How widespread is Alzheimer's and dementia here in Iowa and nationwide? Oftentimes we'll talk about the people living with the disease, but we cannot forget about the caregivers. They go through so much as well, and some of what our program does is try to figure out what resources are out there and what resources are needed for caregivers. And then, because this is not the happiest subject at times, because it's not the easiest subject, there will be some less than ideal numbers and statistics and doom and gloom throughout. But I like to leave you with, is there a reason to hope? Is there something good that is coming out or is already out now or is on the horizon that we can leave today and go, okay, that's better than I thought. Hopefully you'll feel that way too. All right, let's begin with a bit of level setting. Science and culture have not always done the best job of using the terms dementia and Alzheimer's correctly. A lot of times they'll be used interchangeably, but that's not technically accurate. I like to think of a dementia as an umbrella term. It's a category of diseases. And usually dementias, we talk about cognitive function. That's just a fancy way of saying how your brain thinks, how it's working. And dementias are not just the occasional bit of malfunction or issues in cognitive function, but it has to be severe enough to interfere with daily life. And we'll give some examples of that a little later on, but this is not the occasional bit of forgetfulness. This is something that is more impactful, and it happens very often. That is what a dementia is as a category. Now, a lot of people go right to memory loss for dementia. And that is true in some cases, but the brain controls so much more than just our memory. So for a disease that affects the brain, other functions are going to be affected as well. How we think, our reasoning, our judgment, our social skills, our ability to do daily activities, and even the ability of our brain to keep itself alive. All of those are things that our brain controls and are thus an option for something that could be harmed in dementia. Now, really crucially, many dementias tend to be progressive, which means they get worse over time. You'll hear me talk about opportunity windows during this program of, hey, research, this is a great time if we could step in here, or if we can detect this, this would be a great time for us to go to the doctor. This is why. It's a progressive disease, which means it gets worse over time, so time is of the essence. The earlier, the better on the things we'll discuss. So the umbrella of dementia is a category, but what is under that umbrella? That's where you find a lot of different diseases. And you've probably heard of some of these. Aside from Alzheimer's, there's Lewy body dementia, frontotemporal, vascular dementia, mixed dementia, there's Parkinsonian dementia, there's pseudo-dementias. There's all kinds of things that are under that umbrella. The most common thing, though, is Alzheimer's disease. So what sets Alzheimer's apart from some of the other types of dementia? Well, brain anatomy 101 here. Imagine these brains are looking directly at you, and I've gone side to side, whack. So you're seeing cross sections of two brains. Now on the left, this is a happy, healthy, plump-looking brain. It's what we like to see. The wrinkles are nice and squished together because it is kind of plump. You've got these really delicate fan structures where all the neurons are going in the same direction. That looks good. If you've ever heard the term gray matter and white matter to talk about the brain, you can actually see the difference. It looks good. Now on the right, that's a brain that is affected by Alzheimer's disease. And one of the first things a lot of people notice is it's smaller. There's less brain material there. Those nice squished wrinkles have now opened up into chasms as the brain comes inward. And then to counteract that, the brain is poofing out its ventricles to try to make it occupy about the same amount of space. You lose the definition of the fan structure. It doesn't really show it, but you lose the definition between that gray matter and that white matter. And you also may notice these big gaping holes down here at the bottom. Now this is a little stylized, but this is an area that is often affected first in Alzheimer's disease. And can anybody guess what that area is responsible for in our brain function?
Memory?
Memory. It is no coincidence. The first areas affected in this disease are, in part, the places where our memories are held. It's an area, and I'm not going to quiz you on the names, but it's an area called the hippocampus because it looks like a seahorse. And there's other parts that deal with memory too that are not shown here, but those are crucial because usually one of the first symptoms that we see in Alzheimer's disease is short-term memory loss, which means forgetting the recent stuff, the stuff that just happened. So I mentioned that Alzheimer's is the most common form of dementia, but not every case of dementia is necessarily Alzheimer's. There's a lot of different types. This is one of the progressive types, and as you can see, it may start in the memory center, but the whole brain is affected. It doesn't just stay there. So that makes sense then that it's not just memory that's affected. If left long enough, this is a disease that will affect many different things that the brain controls, including some of its most core functions. And interestingly, scientists believe that those physical changes in the brain can actually precede the start of any symptoms, sometimes by up to 20 years. It's kind of disconcerting, yes. So for 20 years, some of these physical changes could be happening, but the person never shows any symptoms during that window. Not ideal, but at the same time, from a research standpoint, if we could step in during that 20-year window and stop the disease in its tracks, that person never had symptoms. They basically never got dementia. We'll discuss how close we are to that toward the end, but we're a lot closer than we have ever been to that point. So now that you know roughly what the disease is, I want to take us back in time to our early understanding. And I don't just mean of this disease, but I also like to think about our depictions of aging. Specifically, what used to be considered elderly. It's not a term that we like to use too much nowadays, if we can avoid it. But you don't have to go back very far, when what we think of as Alzheimer's disease was very linked with what was thought of as natural aging. How many of you have heard the term going senile? Or hardening of the arteries? Very common phrases to describe kind of the same thing, this grouping of diseases, this grouping of conditions. If you go back maybe another generation or two, you enter this time period where, yes, people weren't living quite as long, but it was still very linked with, oh, that's what happens, you know, you get old, you drop stuff, you lose your faculties, you can't live alone, grandma's got to go off to the sanitarium. I mean, that was just kind of accepted as that's what happens when you get old. Now, some of that began to change with that fellow right there. Any guesses on who this is? And he's not a president. I get that a lot. Oh, I hear a couple people mentioning it. Yes, this is Dr. Alois Alzheimer. He was a German physician in the late 1800s and early 1900s, during that time period when elderly meant something very different. And when he was in practice, around 1906, he saw a patient by the name of August Dieter, who exhibited all of those classic signs and symptoms of what we now think of as Alzheimer's disease. But what made him curious is that this disease of the old that she was showing didn't really fit because she wasn't old. She was in her 40s. So that made Dr. Alzheimer wonder, how can this be? How is she showing the signs of aging if she hasn't aged yet? Well, she passed away very shortly after that, and he was able to get slices of her brain tissue on a microscope slide so he could look and see what was going on. Is something standing out as being different? And what he saw 120 years ago this year, we still look for in this disease to this day. Plaques and tangles. If you've ever read anything about dementia, anything about Alzheimer's, you have probably seen plaques and tangles talked about somewhere. That goes all the way back to Dr. Alzheimer and his team. But as you can imagine, in 1906, couldn't go too much beyond that. We didn't have good ways to image the brain back then. We didn't have PET scans, MRIs, X-rays aren't really that effective. So our understanding stayed there for a while. But this is what Dr. Alzheimer saw. These are brain cells floating in space. Now your brain is, at least in part, majority, made up of brain cells. And if you're looking for a really good-looking one, this one right here is a great example. Same thing right back here. I like to think of them in this picture like upside-down trees, if it helps you visualize. So you've got a trunk, and sticking up you've got the roots, and then other way down the trunk, now you've got the branches. Same thing here, trunk, roots, trunk, branches. And all of the brain cells' roots and branches are all tangled together, and each brain cell is using those roots and branches to send the other brain cells messages, chemically, electrically, and that's how thoughts move through the brain. But Dr. Alzheimer noticed that that shouldn't be there. Big, ugly clump of something. That is what he called a plaque, specifically a neurofibrillary plaque. Now that is blocking the brain cells from being able to talk to each other. He also noticed that some of the brain cells just did not look very healthy, like this one over here. it has lost all of its roots and branches. It has shriveled up. It's full of this tangled gunk inside of it. That is what's known as a tangle. So you have the neurofibrillary plaques and you have the tangles. Plaques are in between the brain cells, tangles are inside of them. Well, now we know a little bit more about them. We know that those plaques are made of a protein called amyloid, and that the the tangles are made of a protein called tau. Now these are different than the kind of proteins that we eat, that we take in through meat, for instance. These are structural proteins in our cells. But it gives us a better understanding of what is going on, even if we still, to this day, don't really know what the chicken and the egg is here. Do the plaques and tangles cause Alzheimer's disease, or does Alzheimer's disease cause the plaques and tangles? We're not really sure. Lots of really interesting theories. We can talk about that later. But we know that this is core to the disease. So, to go forward into our current understanding, now that we've established that Alzheimer's disease is a disease, well, we've also learned a lot more about what is considered normal aging. I think we all have images in our head of what aging looks like. Just first things that kind of come to your mind when you picture aging. It's probably got some commonalities, but I can almost guarantee you that very few of you out there are probably including your brain in that picture. But the brain is just as much a part of our body as any other part. And it will go through changes as it ages. Now, some of that you hope is a good thing. Maybe you have an increase in wisdom and expertise and worldliness and experience. We all know people where that's not true, but ideally that's what should happen. But on the flip side, yes, the brain does slow down a little as it ages too. It may take an extra beat to remember a word or a name if somebody comes up to you. Remember, you've had that experience where somebody comes up and they know your name but you don't know theirs. That's awkward. But that is normal aging for the most part. Especially if you kind of remember where you know them from, or later you go, oh, that was who I was talking to. Totally normal. That happens. Maybe you are struggling to remember, hold on, is it Wednesday? Is it Tuesday? No, it's Wednesday, right? Thursday? 15th? No, I don't know. That's normal aging. It happens. Getting mixed up on the day of the week, the date, totally happens. Forgetting where you set your keys. You cannot find your keys no matter where you look. So frustrating, especially if it happens more often than not. But for the most part, that is normal aging, that bit of forgetfulness. Where we would differentiate that from not normal aging is if you finally found your keys, you picked them up, and you don't know what they do. That would be a bigger issue that is out of the norm for regular aging and memory. Let's say you worked at the same job for 20, 30 years. You go to work one day, you sit down at your desk, and you just can't remember what. I feel like there's something I always do. What is the first thing I always do when I sit down here? That's out of the norm, not normal memory. You're driving across town. You've lived here maybe all your life, maybe 50 years or more. And suddenly you get turned around and you're in a part of town that you don't recognize, and you're not really sure how to get back to somewhere you do recognize. That is out of the norm of aging. Now, none of those things in and of themselves are diagnosing dementia. That doesn't mean you have dementia, but something is going on there. So it's worth getting checked out. Really important to check out any changes in memory early on. Those sorts of things are not normal aging. A little bit of slowdown, once in a blue moon forgetfulness, that is. There is a difference, and there's some really good resources out there that we can talk about later that differentiate what some of those are. Now, for some people, that normal slowdown for aging will happen for the rest of their lives. For others, though, they'll notice some of those red flags. Something will start happening. This is when they enter a period of what's known as mild cognitive impairment, or MCI. MCI kind of represents this in-between stage. It's not normal aging, but it's not full-blown dementia. But you can tell something is happening there with memory and cognition. Something needs to be checked out. Now, I bring up MCI for two main reasons. The first one is If somebody is diagnosed with MCI, they are at an increased risk for going on to develop dementia themselves. The other reason, and perhaps the bigger reason, is that many causes of MCI are reversible. There's a lot of things that can cause your brain to be fuzzy. Maybe you haven't slept very well. Maybe you're really stressed. Maybe it's a vitamin deficiency. Maybe you're coming off of an infection or a sickness. Lots of things can hamper our memory. Enough to show up on a test. But that doesn't mean it's dementia. And if you fix those fixable things, a lot of times the MCI goes away and the person sees their risk drop for developing dementia later on. Now this may be confusing, but for some people, the reason why they are getting MCI is the start of dementia. But there's no good way to differentiate, is it a reversible cause that's causing this, or is it dementia that's causing it? There's no way that we can just look at that ourselves and go, I'm betting it's this one. You need a doctor to tell you for sure. They can help to suss that out and figure out which one it is, but only if you go in early enough. All right, quick recap. I know we've covered a lot here. Alzheimer's is the most common form of dementia, but it's not the only form. Dementia is a category of diseases. It starts in the memory center, which is why we think about Alzheimer's being with memory loss, but it doesn't stay there. It affects the entire brain if left long enough because it is progressive. It is not just a disease of the old, like many people thought for many years. You can have what's called younger onset. Now, clinically, that's diagnosed anybody under the age of 65. That's considered younger onset. That's pretty rare, but it can happen. It certainly happened with Dr. Alzheimer's patient who was in her 40s. Now, despite all of this, the brain is a very complex organ. So no two people are going to go through this disease in the exact same way with the exact same symptoms at the exact same time. Alzheimer's is going to look a little different for everybody. There will be some commonality, yes, but people will vary, and people will sometimes vary day to day, week to week, sometimes hour to hour. But the main thing here is that Alzheimer's disease is not a normal part of the aging process. It is a disease. Now that does beg the question, of course, how do we get it if it's a disease? I know what I just said, I know. But the number one risk factor that science has identified is our age. Let me explain. This is not an eventuality of if you live long enough, you're going to get Alzheimer's. It's not the case. But the older a person gets, the higher their risk gets for developing. Put another way, somebody who is 50, their chance of developing Alzheimer's in the next year is pretty low compared to somebody who's 85. Doesn't mean that either one of them is going to get it, but their risk is different. If you want to quantify it, past that age of 65, when we talk about normal onset Alzheimer's disease, every 5 years after the age of 65, a person's risk for developing Alzheimer's doubles. 65 to 70 doubles. 70 to 75, that doubles. 75 and up. So once you get past age 80, around 1 in 3 older adults will have some touch of this disease. Second biggest risk factor is our genetics, our DNA, our family history. We've learned a lot more about the specifics of those genes and the relationships that they have to us, but time and time again it comes back to the fact that the more close relatives a person has, who they have dementia, who they have specifically Alzheimer's, the higher that person's risk is going to be. And I'm not talking like third cousin twice removed when she was 95, probably not going to affect your risk that much. But if you come from a family where maybe your older brothers and sisters are getting it, maybe your parents had it, maybe their parents had it, your risk is going to be higher than somebody where it doesn't run in their family at all. But in the wisdom of science and public health and risk, it's never a guarantee either way. There are people that have a strong family history and they never develop it. There's people that do not have a family history and they do. It's never a guarantee. So what can we do to make sure we steer one way or the other? Well, that's probably the third biggest risk factor. Our lifestyle. And, coincidentally, that's the only one of these three that we can actually control. You even though we'd love to try on the other two. We can't control these, we try. But lifestyle, we can. That's been heavily studied, especially in the last 10 to 15 years. What can we do to take the power back and try to lower our risk? Now for some people though, no matter what they do, they are already at birth going to be naturally at a higher risk than somebody else. For instance, out of everyone living with Alzheimer's today, 2/3 are women. It is not a 50-50 split. And we don't totally know why that is. Lots of really interesting theories, even when you control for the fact that women do tend to live longer here in the US than men, there's still a difference. We're not really sure why. Also, different races have different levels of risk. In the African American community, they are twice as likely to get Alzheimer's as Caucasians are. In the Latino community, they are 1.5 times more likely than Caucasians. We don't totally know why this is. Even when you control for social determinants of health and some of the things that these populations experience, there's still a difference. Lots of really interesting studies, but we're not quite there yet in knowing why this is the case. So what can we do, regardless of our background, to take control? When I started giving programs about 10 years ago on this subject, this list looked pretty simple. Basically back then the best we could do is say diet, exercise, keep your brain active, don't be lonely. Okay, well, that's a good start, it's better than nothing. But in the last decade, we have learned so much more about why those things were on the list, and then some specifics to make them even more effective. And what keeps coming to the top of the list, especially with some massive data releases in the last couple of years from multi-year studies, is that heart health equals brain health. What is good for your heart is good for your brain. Specifically, they found a very strong indication for managing blood pressure. This was another one of those multi-year studies, and what they found is that people who could get their target numbers, they always give you a top number and a bottom number, the people who could get those numbers down to 120/80 or lower had a significantly lower risk for developing dementia. And it was even different than people who still did well at lowering their numbers, but they only got them down to like 140 instead of 120. There was still a stark difference between the 120 and lower group and the 140 group. So the closer you can get that top number down to that ideal, the lower your risk for developing this disease will be. Now, how do you do that? There's a lot of ways. Remember the old list had diet and exercise on it? It's still there. But in part because it helps to lower blood pressure. Now we understand why we had those on the list in the first case, why we talked about the Mediterranean diet and the DASH diet. What is the DASH diet? It is literally in the name. It's the diet for hypertension, for lowering blood pressure. This is even true if you take medications, for instance, to lower your blood pressure. If that is helping to manage it, that risk is still coming down. Maybe not quite as much, but it is still coming down if you manage that blood pressure. Keeping the brain active has always been in the running up there. And when you read the studies about keeping your brain active, you'll often see the term formal education used. And that doesn't always mean, did you get your degree from Harvard or Yale? It's not what we're talking about. What this normally means is, are you engaging in learning over the course of your life? Are you keeping your brain active by taking in information and growing your knowledge base? I don't know, maybe by going to a library to watch a program and stuff. It's an option, I don't know. But that would be an example. It's not exactly if you don't use it, you lose it, but I would treat it that way anyway. It's a good mentality to have. Push your brain out of its comfort zone. And if you can do it with other people, that actually adds some brownie points as well. That helps to lower risk. People who are more social report feeling more connected, more supported, they have fewer hospitalizations, they tend to live longer, they tend to say they're happier. It's good to be connected to people. So anywhere in this that you can connect with others, you're adding to it. Now some things have been working their way up and down the list in the last few years. And one of the ones that's been on the rise is untreated hearing loss. This is an interesting one. What they found is that people who had a hearing loss, they were actually at a much higher risk for developing dementia than those who did not have a hearing loss or whose hearing loss was treated. Now, if you think about why this is the case, there are parts of our brain that specialize in hearing. So they're sitting there and they're getting the signals that are coming from our ears and they're sending them off to wherever they need to go. But if somebody has hearing loss, those parts just kind of sit. They wait, and they're waiting for signals. Maybe the signals are not very strong, so they don't have as much to do. The brain doesn't like to be bored. So that part of the brain, I'm not kidding, will either go do something else, or it will shrink, it will disappear. So treating that hearing loss actually lowers the risk back down for dementia because the brain is active again. The brain likes to be active. There's other things on the list where we have learned more about them, even though they've been on the list for a while. Sleep. We all know sleep is good for us. Easier said than done, but we all know that sleep is good for us. Restful sleep, a proper sleep cycle with deep sleep, REM sleep, all of that helps to consolidate memories, clean out waste, it's good for the brain. But recent research has found that people who take sleeping aids to fall asleep, their risk is actually quite a bit higher than somebody who does not. This is very specific to a class of sleep meds called anticholinergics. These would be, for instance, medications that have PM in the names, like Tylenol PM, also things like Benadryl. The reason why that is the case is because, yes, lowering acetylcholine actually does help us to sleep, but what do you think is one of the chemical messengers involved in memory formation? Same thing. So if you're reducing it through medication, you might fall asleep, but you're also reducing a key part of your brain's memory system. Good news is there are natural sleep aids, and there are different classes of medications that can help as well. So sometimes you hear about orexin antagonists. Those don't have the same effects. Those do not tend to raise risk. Melatonin is something people ask about often. Usually some people will say that it helps them. It's going to be kind of dose dependent. Talk to your doctor on that, but it does not seem to raise risk. Also, something that can help you get sleep, like a CPAP machine. That lowers risk as well. Treating sleep apnea oxygenates the brain better, you get better, more restful sleep, and that lowers risk. We've also learned more about the lung and brain connection. Now, we've known that smoking is not ideal for a long time, but recent research has found that people who stop smoking, their risk within 4 to 7 years for developing Alzheimer's actually comes down to the level of somebody who never smoked. That surprised me when that study came out. I thought once the damage was done, it was done, but no, they said it actually does help. Air pollution is another one that's kind of new on the list, and we don't totally have the answer to it. Specifically, this is looking at a size of particulate matter in the air that we see a lot here from wildfire smoke.
Wow.
So I would say stay tuned on this one. We're not really sure why that is or what the details are, but it does seem that repeated exposure to that size of particulate matter can raise risk. Now, maybe the things on that last slide were not quite up your alley. The good thing is, keeping an active brain is something that anybody can do at any time, anywhere. So what does this look like? It could be different for everybody. But the idea is you want to push your brain out of its comfort zone. If you do something and it's second nature, it's not really challenging your brain. Just like you would a muscle, you want to lift something a little bit heavier than what you think you can do, same idea here. Do something that you have to think about. When you do that, you are building up what's called a cognitive reserve. Anybody heard that term before? It's really interesting. It goes back to a study in nuns in a convent. I can tell that story later if you want me to. But the whole gist of it is you are building up a more resilient brain. And the higher you build up that resilience, if there's a disease that's trying to pull you down, it's got to pull you a heck of a lot farther before you start showing symptoms. So, we're in a library. How about reading? Yes, reading is an option. Read a different author than what you're used to. Or maybe read a book you've never read before, at the bare minimum. Go from fiction to nonfiction. Seek out something you've always wanted to learn but you haven't had the chance. those sorts of things can help you. And again, if you can do it socially, extra points. All right, so why do we talk about this? How widespread is this disease both here in Iowa and nationwide? Spoiler, this is where there are some numbers that are not great. So I said, okay, what's something that we can do just to keep spirits up? So we said, oh, audience engagement. Audiences love that. So this is a true or false question. Alzheimer's is one of the top 10 leading causes of death in the US. There's a lot to parse out in this one. Wish it were a peppier question, but anybody for true on this one? Okay, we've got some slow hands coming up, all right, getting more and more, all right. Anybody for false? All right, we're kind of split. We're kind of even on this one. Well, a few months ago, we just got the updated numbers from 2025, and now that COVID is out of the top 10, Alzheimer's has kind of assumed the same position that it did before, and right now it's true.
How do you know the people that passed away didn't have Alzheimer's?
I'd say it again.
How do you know those people didn't die from something else besides Alzheimer's?
So, to kind of quantify this, when we say sixth leading cause of death, the way that Alzheimer's is classified is universally fatal, which means once you have the disease, you are going to have it for the rest of your life. So then we look at classifying it. What role did it have in the death? Now, in a lot of cases, Alzheimer's ends up being a contributing cause of death. So for instance, it causes a behavior where somebody gets injured, or it causes something to happen where they get sicker, something occurs because it wouldn't have had they not had Alzheimer's. But there are some cases where it is a direct cause of death, when that part of the brain that keeps us alive and maybe does a core function is destroyed. Now that can be hard to get on the proper documentation. And to be honest, the numbers that we have probably don't include everybody out there for that reason. Not every coroner, not every medical examiner is going to put that on as either a contributing cause of death or as a direct. So the numbers are maybe a little bit low on that. But these are the best estimates that we have based on the population numbers and the incidence and the prevalence that we have as well. So, yeah.
But people are living longer and longer now because of better health, better doctors, better medicines, you know. Men used to die when they were 65, and women lived on to be maybe 75.
Yep.
And now people are living to be in their hundreds and 95. And we've got people that are 95 and they have excellent brain yet, you know. It's just the way it is.
Yeah, we do see a difference. So what this looks like nationwide is that there are around 7 million adults who have this disease that we know of. And there's a new case roughly every 65 seconds. So think about the time that we've been here. That's quite a bit. When I first started giving these programs, that number was around 70. So it has picked up the pace a little bit, in part because we are an aging nation. We are living a little bit longer. So the projections are for that number to almost double by 2060 if we don't have something between now and then that can slow down or stop the disease altogether. And you can imagine, already with this many people, but certainly this many, are going to have a lot of costs associated with them. It's going to impact people both financially and in life, quality of life. Here in Iowa, we see similarly high numbers, but we are a little bit higher than some of the other states around us, in part because, no surprise, we are an older state as well. So there are around 62,000 Iowans who are estimated to have Alzheimer's disease, with around 100,000 caregivers. So I said at the beginning, I talk about people affected by this disease. I don't just mean those living with it. There are a lot of caregivers who are affected by this disease, just in a different way. Iowa, I mentioned, is an older state. We're 6th in the nation for how many people in our population are above age 85. And I think we're 2nd in the nation for how many of those 85-year-olds are still working. So early on in our program's existence, I wanted to get a picture of how is this state equipped to receive these people? What resources do we have? What resources do we need? So we did a landscape assessment with the University of Iowa. And what they found is, first off, we're looking at how many primary care physicians there are. That's often the first line of defense that people take when they notice something going on. But what we found is just 38% of primary care doctors are in rural areas. So that seemed to be a little short. Maybe if you want to go to a hospital that has a section that is just designated as, I will diagnose Alzheimer's. We call those memory care clinics. Iowa only has 6 of them, and they are all located in urban areas. That is the lowest of any neighboring state around us, 6. Wisconsin, they've got 40.
Wow.
We have 6. So that was another opportunity we need to pick up the pace a little. If you want to just break it down from people to doctors, look at it a different way. There are around 1,200 Iowans for every 1 family care doctor out there. Now, obviously not every doctor is going to see that many people, but if we change that and go from family medicine to neurologists who specialize in the brain, there's even fewer of those. So now it's 5,000 to 1. If you want to go for geriatricians, so doctors that specialize in older adults, they're even rarer. 15,500 Iowans for every 1 geriatrician we have. This told us early on in our program at Iowa HHS that we need to change our approach with how we address these doctors, how we address the shortages. So our program's been kind of working behind the scenes with training schools, medical schools, licensure, a lot of different things to expose more students to this line of work, to let them know this is a viable option. And then we're also having to go through some other things to make sure that we can get them interested and keep them here. This is true for community health workers, direct care workers, on and on. Audience engagement. This is a multiple choice this time. What percentage of Alzheimer's care in the U.S. is provided by unpaid caregivers? Would it be 23, 43, 63, or 83? Anybody for A? All right, we have no optimists. Anybody for B? Nobody tempted on that one. C? Any temptation there? Oh, we're getting a few. All right, D? 83? What a lot of pessimists, my goodness. Unfortunately, though, you are correct. This one surprised me. I was not expecting this when I first saw this number. No, you're absolutely right. 83% of all care for Alzheimer's in the U.S. is given by unpaid caregivers. And why it surprised me is because I probably had the same misconception that a lot of people do, maybe not you because you got it right, and that's where these people are. Contrary to what you think, 70% of people living with Alzheimer's disease live in the community. They're not in care facilities. They're not in specialty units. They live, they work with us. We see them every day, whether you know it or not. They use the same services. They come to the library. They're all around us. That is why so many of them have so many caregivers and so many other people who are affected by it, because 25% of them live alone. And that's not sustainable. But 70% live in the community, and a lot of people do a great job of making sure they can stay in the community as well. Those 7 million who have the disease have over 12 million caregivers. And they provide a lot of care they don't get paid for. So who are the caregivers? Well, just like the people living with the disease, 2/3 of all caregivers are women as well. Many of whom are now in this sandwich generation, where they're taking care of their own kids, but now they're having to take care of their aging parents as well. A good chunk of them are still working, many of whom work full-time. And over half of them have been doing that balance for over 4 years. Caregiving is tough. It's a very small nutshell to put it in. Caregiving is difficult in every facet of the way. Social, psychological, physical, emotional, financial, on and on and on. Caregiving is tough. And what the caregivers go through is very real and very difficult as well. 62% here in Iowa say that they have ended up with their own health concerns that maybe they didn't have before they were a caregiver. But so many of them cannot take the time to take care of themselves. That altruism that drives them says, no, I've got to take care of my loved one. I don't have time for me. I'm not as worried about myself. That's very common. Often, this has big impacts. It has impacts to the healthcare, to the workforce and the healthcare system as well. So in our program's early existence, we said, okay, this cannot be a forgotten group. We have to build out resources for caregivers. So we tried to figure out, first off, what is out there, and can we partner with them and start to increase their infrastructure? One of the first things that came up, we've already mentioned today, are the area agencies on aging. If you're not familiar with these, there are 6 of them around the state, and each one is kind of a specialist in its own counties. And they're all named something different. The one that covers here is Elderbridge. So we heard about Elderbridge at the beginning. Sounds like they're pretty active, which is good. But they really only see statewide about 3% of Iowa's population in a given year. So we said, okay, we've got to work with them more. So we're in between printings right now, but we actually developed a compact but really dense dementia resource guide with the Northeast Iowa Area Agency on Aging, because they're the home of dementia-friendly Iowa. So that's on our website. Once we get more printed, I'm going to mail them to the library here so that you can have those. But it's a good guide for whatever connection you have to the disease. There's something in there for you resource-wise that can at least get you started on your journey. Also, I mentioned earlier the Alzheimer's Association. Worked for them for a little bit. They've undergone a lot of change in recent months, so I wanted some resources to pull out that anybody can find regardless of where you are. The first of these is called the Community Resource Finder. This is a website where you put in your zip code and it shows you by distance what is nearest to you. And they have a lot on there. It's education programs, support groups. It's where you can get care consultations. It's diagnostic clinics, AARP, home health, respite care, on and on and on. There's a lot on that website. They also offer some of those things virtually or over the phone. So if you aren't able to go to them, you can still get connected. They also run a free 24/7 helpline. It's based out of Chicago. It's staffed by master's level clinicians and above. They take tens of thousands of calls every single year. I used to have a weekly radio show over on KVFD about brain science, and I had the head of the helpline on my show because I wanted to know what goes into the training. What does it look like if somebody calls? And they do a good job. They're called the Alzheimer's Association, but first off, they do all dementias, not just Alzheimer's, so don't let that dissuade you. They have real people. You don't talk to a machine. They keep good notes, so you don't have to explain yourself every single time you call. You can call them at 3 in the morning and say, my loved one's doing this, and I don't know how to react. What do I do? They can help you. You can call them and say, oh, I'm dreading this. I think it's time for Dad to stop driving, but how the heck do I talk to him about that? They will help you have that conversation. They'll role play, they'll give you some strategies. Maybe it's, hey, it runs in my family. I don't want to get it. What can I do to lower my risk? They'll help you. Really make use of them. I'll put all this up on the last slide. Also, some people just say, give me a list. Whatever, I'm not going to worry about that. Just give me a list of what I need to do. That's what All's Navigator in part is. It just gives you kind of a step-by-step of planning out your journey with this disease, either as a caregiver or somebody who's been diagnosed. It's a good step-by-step. Something else we've been working on is the annual Medicare wellness visit. Really great concept. The idea behind this is anybody on Medicare once a year can go in and get a wellness check. It's not really a physical checkup, but it's a wellness check. And by definition, that should include a cognitive screen, which detects for memory changes. In reality, it's not always that simple. We have learned that there is massive variability in how the annual wellness visit is administered.
Yeah.
Only 25% of Iowans on Medicare ever use it to begin with. And not all doctors do the cognitive screening. Not all of them do the same cognitive screening. And I'm not kidding. I've literally had doctors say, I normally just ask them, hey, how's your memory been? You can't do that in this disease. It's not how it works. So what we are trying to do is we're working with health systems and we're working with doctors across the state to standardize this a little bit more. The idea being, if they can all give you a similar test, like the mini-cog, that will really help in early detection of Alzheimer's. Now, what is the mini-cog? It is a short and it seems like a silly test. If you've ever seen the whole draw the hands on a clock, I'm going to ask you a couple of questions and give you some words and you got to remember them later. Seems really silly, right? But statistically, that test is really good at detecting subtle memory changes. Only takes a few minutes. Anybody can give it, doesn't have to be a doctor as long as they're trained to give it. So we're working on how do we expand that out there. But the thing is, like I said, most people don't get it, or most people don't get it until they have symptoms. Now in part, maybe that's because you hear that test and you go, I can ace that. Then do it. You should do it because Now you have a baseline. And most people never get a baseline. Most people go in when they have symptoms and the doctor says, here's your results, and they go, is that good? The doctor goes, I don't know. I mean, here's how you compare to the average. But if you had gone in when you could think you ace it, maybe you went in a couple of years ago, man, that was easy. Okay, why are you scoring different now? Most people never have that baseline. Please go get it. Please go get it. There are other groups that are throughout the state that we are trying to make more of. For instance, support groups. Really useful, really helpful, but kind of few and far between in places. So we have partnered with both the AAAs and with the Alzheimer's Association to where if anybody wants to start your own support group in whatever town you are in or wherever you might think there's some usefulness to it, we have the resources, we have the training that can help you do it for free. If you want to start a support group, let us know. And there's multiple types of support groups. There's caregiver, there's people with the early stage of the disease, they can go to their own support group. We have a young adult caregiver support group, we've got a men's caregiver support group. There's multiple languages, some are online, some are over the phone, not just in person. We're trying to make this accessible because research shows it does help. Anecdotally, people say, man, it really helps, because otherwise I felt alone. I didn't know that so many others were going through what I'm going through, and there is power in that. Another thing is respite care. Awesome concept. Needed everywhere. But why isn't it everywhere? It's very frustrating. There are not a lot of respite care places in the state. COVID knocked us down a few more. But since then, we've started to see a few communities actually start their own using a volunteer-driven model. So we have gathered those together. One of them's in Fort Dodge, there's several others around the state, and we've got them talking to each other, and we're saying, how did you make it work? How did you sustain it? I'm working with the National Association of Adult Day to figure out, can we get a guide for how to start one of these here in Iowa? Why are the barriers so high? Why aren't there more of these? What can we do to lower those barriers, get people the information they need to start it and sustain it? Now, some of that is outside of our hands legally, but what is in our control, we're going to try our best to make that accessible to anybody. It's a longer road ahead, but respite care, by the way, if you're not familiar with respite care, this is somewhere where you could take your loved one for an afternoon, a morning, a whole day, drop them off, they are taken care of, they're engaged, they're with other people, and you as a caregiver can go do whatever you need to do. If it's get groceries, if it's clean the house, if it's take a nap, take a walk, go to the doctor yourself, whatever it is. It gives you respite for that time period. Awesome concept, but again, we've got to get more of them out there. All right, so I'd like to leave you with, is there a reason to hope out of all of this? Yes, there were some numbers in there that made us go, ooh, that doesn't sound good. So what does sound good? For the first time ever, within the last 2 years, we now have multiple medications that can slow down